I was never, ever told all the time when I was having radiation that you could have a radiation disease and that the radiation could carry on after the treatment and burn my bowel, my bladder and the complete pelvic area. Nobody actually sat down and told me that.
It was done in the June, and for a year and a bit I was perfectly all right and able to go about my business again and go on holiday and everything. And then it just gradually started, and it's never really stopped since. All these after effects, side effects.
I wish they'd just left me alone, because I would rather just be dead than living like this. This isn't living being like this. I think this is worse than having the cancer.
The Christie Hospital in Manchester enjoys an international reputation as Britain's leading cancer centre. It treats thousands of patients each year, about 400 of them for cancer of the cervix. Radiotherapy is an inherently destructive form of treatment. The art of the radiotherapist is to give enough radiation to kill off a tumour without permanently damaging the patient. For 50 years, the so-called Manchester radium system produced a remarkably high cure rate for cervical cancer with few long-term side effects. 12 years ago, radiotherapists at the Christie Hospital began trying out new techniques for treating cancer of the cervix. In the years that followed, the hospital's surgeons were faced with an unprecedented increase in the number of patients suffering long-term radiation disease in their bowel or bladder. The symptoms are humiliating and often crippling. For some patients, they've proved fatal. The Christie's new treatments did not improve the already high cure rate for cervical cancer, but they left many women with permanent radiation damage. Some patients complain that they weren't told that new treatments were tried out on them, and lawyers are preparing test cases for compensation. The Selectron machine keeps a store of radioactive pellets shielded inside it. Once it's been programmed, it loads them into a precise pattern and then pushes them down a long tube into a hollow metal prong. The prong has already been pushed under anaesthetic into a woman's cervix next to the tumour. As long as she lies still, usually for several hours, her cancer is now getting the most direct form of radiotherapy. The idea of pushing radioactive sources inside patients by hand is almost a century old. What the Selectron machine offers is a way to do it by remote control, without doctors and nurses having to handle radium. For the patient, it offers technological precision, but not much of a bedside manner.
It looks like a little Dalek in the middle of the room, and it has 6 arms out. 3 go to one lady and 3 are connected to you. Both beds are protected by a LED screen. An operator comes in, then she programs the Selectron machine. She leaves the room and then all the room's locked up, and then you're left in this room. But it was very painful in a way that I can't really describe. A woman would understand how a vagina would feel if there was about 6 Tampax inserted into it. That's the only way I can describe it.
In 1978, the Christie became the first hospital in Britain to buy the Selectron. They bought a pair of them using money raised by a women's cancer charity. Unlike microwave ovens, radiotherapy machines don't come with a book of clinical instructions like cooking times. It's left to the hospital to decide how much radiation to give patients and how quickly. The Christie doctors realised that with the nursing staff well protected, they could use more intense radiation to give patients the same dose in a shorter time. Under the old system, patients lay with a radium pack inside them for 3 full days. In the Selectron machine, the hospital used a different element, cesium, to give more than 3 times the dose rate, cutting the treatment time from 72 hours to just 20. It was as if they were giving patients a suntan in less than a third of the usual time. We've spoken to the radiotherapist who introduced Selectron to the Christie, Dr. Robert Poynton. He and his colleagues thought a shorter treatment time would be more tolerable for patients, and the hospital would get the economic benefit of using expensive machine time more efficiently.
With a machine of this type, the more you can use it, the more it makes economic sense. And therefore we wanted to be able to use it as frequently as we can to cope with the patient load. On a 5-day working week, about 250, 260 patients a year, or 260 applications a year. So that with the 2 machines we had, that went to over 500, which would satisfy the load that we anticipated.
Whereas if each treatment had taken 3 days...
You would need to have a battery of machines to cope with that sort of load.
After a small pilot study in October 1980, the doctors began a clinical trial to compare less than 1 day on Selectron with the traditional 3-day radium pack. They had to decide what dose to give patients. There was scientific advice from the hospital's radiobiologists who tested the more intense radiation on mice and concluded that the total dose should be cut by 1/3. The doctors were not convinced that experiments with mice were a reliable guide to human patients, so they had to balance the risks. Too high a dose would cause greater side effects, most of which could be treated. But too low a dose would cure fewer cancers, leaving more patients to die. They decided that half the patients having only Selectron would get the full traditional dose with no reduction at all, and the other half would get a slight reduction of less than 7% to see what happened. One of them later wrote in the journal Clinical Radiology.
It was thought that any dose rate effect was likely to be small. Clinicians with a long experience of radium implants doubted whether the higher dose rate would be detectable clinically.
They were wrong. They and many of their patients know now that both doses were too high. But when they began using the Selectron machine, doctors knew only that they were testing an unproven procedure. So what did they tell their patients about it?
It was not our practice at that time to inform patients in detail. We would tell them that they were in a study and that we thought that this treatment was as effective as any other treatment and maybe more effective. And that was what was told to them, yes.
But initially they were told what?
Well, they were told that they were going to have a slightly different form of treatment. In the very early days, half of the treatment was done with the Selectron and half was done with the old manual technique. And as I say, it then evolved, but patients were told what they were going to have done to them, how long they were going to be in a room, etc. But they were not actually told that they were subject to a clinical trial in the if you mean in the informed consent situation.
Joanne was just 25 shortly after her second child was born, when she developed cervical cancer. In 1981, she was sent to the Christie Hospital for radiotherapy. She got what most patients get, a combined course of external and internal treatment. But in Joanne's case, both the external pattern of X-rays, known as Hex 2, and the Selectron she was given internally were new and being tried out at the same time. So what do she and her husband remember being told about her treatment by the Christie doctor?
I would have been, very worried if they'd said it was a trial and do you mind if your wife, goes through this, that and the other. From the way they told us, it was a simple, operation, if you want to call it that, and everything would be okay.
Just that I'd have the runs whilst I was having the treatment, and that was all. That it would just be X-rays, that it wouldn't hurt or anything, and that I wouldn't have a scar. I'd just have these little black dots. And it sounded as though it was the ideal thing.
Did you ask about side effects?
No, because the way they put it over, it was just nothing could go wrong. The only thing that they said was that we wouldn't be able to have any more children. That was sort of as though that was the worst thing that could happen to you.
Like the most important thing, about the treatment.
Joanne suffered the immediate diarrhoea she'd been warned about, and after it cleared up, she returned to work thinking she was cured. Well, her cancer was cured, but 4 months later, she began to suffer increasingly harrowing symptoms of radiation damage.
I just started losing blood from my back passage, a real lot of blood. And so I went to the hospital, to Christie's Hospital. And then when they realised how bad it was, they said, well, I'll transfer you to the surgical part of the hospital, and I would probably have to have a colostomy.
And is that what happened?
Yes, they removed a large part of the bowel, when they did this colostomy.
Did they tell you what had caused this problem?
Yes, yeah, they did say it was radiation damage. I had it for a few months, the colostomy, and then they sent for me to go back in to reverse the colostomy so that I wouldn't have it. I was all right for a couple of months, and then I got a fistula between my front and back passage.
What's that?
That's a hole between your front and back passage. So that faeces were actually coming through my front passage, and I had no control over it.
Were you in hospital when this happened?
No, I was at home.
What happened?
Well, I can remember that I was just lay on the settee and I just couldn't move from the settee because if I stood up, it would sort of come out. So I just virtually lived on the settee, and I would get into a mess, wouldn't I remember? And at first, at the very beginning when I noticed that there was something coming through my front passage, my own doctor came, my GP, and he said that it couldn't possibly be faeces because I've had an operation to cure this. And anyway, it gradually got worse, probably because the hole was getting bigger. And when I went to the Christie, the doctor who was examining me could actually see the faeces coming through, so then they believed me. And then I had a second colostomy.
Joanne wasn't the only patient damaged. There were suddenly many more than usual coming back months after treatment with symptoms of radiation disease in their bowel or bladder. Some were bleeding badly, some had burning pains, some were incontinent. Kidneys had failed. There were chronic perforations and abscesses of the bowel. Some, like Joanne, had fistulas, holes burned in their internal organs. The task of repairing the damage fell to the Christie's surgeons, who'd previously seen radiation diseases in only a few patients from the traditional treatments. By the end of 1981, they and the radiotherapists discussed the increase in numbers and what could have caused it. Two facts were inescapable. Apart from an atomic explosion, the cause of these diseases is radiotherapy. And in the northwest region, all radiotherapy is conducted at the Christie Hospital. By May of 1982, Dr. Robert Poynton and his colleagues were worried enough to make two more changes at the same time. They abandoned Hex 2, the new external treatment, for fear of overdoses, and they cut their doses in the Selectron trial.
After a while with treating the Selectron, there were some reports from our clinics throughout the region that there were some increased problems which were had not been seen very often with the old technique. And in view of this, some very careful studies were done to see what was the possible cause for this and to eliminate it. I think the problem that worried people most was damage to the bowel, I think, was the primary problem, particularly to what we call the small bowel. And this was a problem which was well known about and recognised from other treatments, but there seemed to be an increased instance of it, and which was clearly undesirable, and it required far greater surgical interference than one had experience of in the past. And so that is when some alterations in dose were taken, and a careful look at the applicators, etc., was undertaken at the same time.
So, 18 months into the clinical trial, both the full dose and the reduced dose were cut by about 7%. The doctors knew this was still a calculated risk to be proved by its effect on patients. What did they tell new patients about the possible dangers?
Nothing. Just said it'd cure me. I said they'd already told me I had to have hysterectomy. He said, oh, that won't be necessary. He said, this treatment will cure you without surgery.
And did he mention the possibility of any side effects?
No, he didn't say anything at all, no. He just said, you'll have these, whatever they call them, put inside you, and you'll be so many hours, and that was it.
Mary is in her 60s and lives in a small terraced house with her husband, who's just retired. In 1982, she was found to have cervical cancer and was sent for radiotherapy. She was treated at the Christie Hospital just after doctors had cut their doses on the Selectron machine because of the damage to patients. But she has no memory of being told even that there was a new treatment on trial. She saw women in the ward having traditional radium packs and was surprised when she came round from the anaesthetic to find herself in a sealed room.
I said, "Where am I?" You see, and I was very distressed. I think you had a bell that you could ring. And I said, "What's happened? Where am I? What am I doing here? And what's happening?" And she said, "Oh, they changed the treatment at the last minute." She said, "And I did tell you," she said, "as you were going in to the anaesthetic room." She said, "But I didn't think at the time that you'd really understood it because of the pre-med." Well, it was well away. I didn't know. And so she said, "We changed the treatment, you're having this other kind now." Now, she may have said Selectron, but like I say, I wasn't really taking it in at the time.
Mary had 2 treatments on Selectron a week apart, the standard pattern. She had no external radiotherapy. A year later, she felt a burning pain in her bladder while she was away on holiday. Over the next 3 years, Mary's diary filled up with one hospital visit after another.
Friday the 4th of April, 1986, operation day, urostomy performed. Woke up in a side ward, feeling more dead than alive. Saturday, still bad, tubes everywhere. My husband came to see me. Sunday, still bad, on liquid-only diet.
In the urostomy operation, Mary's bladder was replaced by a plastic bag which she wears on her waist. But at first, she hadn't connected the burning she felt with radiation damage. As she came back from holiday in 1983, she went to see her GP about it.
Well, I kept wanting to go. So I had cystitis before, vaguely, so I thought, well, I've got it again. But it never cleared up, and this went on for 6 weeks. And in the end, he realised it couldn't be cystitis all that while. So I said, "Right, we'll have you back to Christie's and see what they can do for you." I just tried everything. I had tests down, tests up, drugs, starvation, x-rays, all sorts.
And meantime, were you getting any better?
No, in fact, it got worse. And I started getting bleeding problems from the back passage. So I was then sent to another doctor in Christie's, and I was given more tests and these barium enemas and x-rays and goodness knows what, most uncomfortable. After all this, they decided that it was the lining of the lower bowel had been damaged by the original radiation treatment.
At the end of 1982, shortly after Mary was given radiotherapy, the Christie Hospital again reduced its Selectron doses by a further 7%. But that upset the other side of the balance. The cancer cure rate fell, because the new lower dose was too low to destroy as many tumours. As the trial proceeded, other cancer centres throughout the world were buying Selectron machines for their own use. The manufacturers brought them together for conferences to pool experience. At the 1984 conference in Innsbruck, the first speaker was from the Christie Hospital, Dr. Robin Hunter, now the Christie's medical director. He told the conference the original doses the Christie had chosen. They turned out to be by far the highest reported to the meeting. Dr. Hunter also gave results from his study of patients with early cervical cancers treated in the trial. Some data were particularly worrying, those for women who'd been given the full dose on Selectron.
In the spring of 1982, we realised that we were encountering significant problems with some patients. Minor and major problems have been experienced by almost half of the patients.
We've established that these problems set off an argument among the Christie's radiotherapists. One of those involved has spoken to us of hot blood and strong words. One doctor worked late into the night, meticulously going through hundreds of patients' histories to find out how many had suffered radiation disease from the new treatments compared with the old. His statistics are not accepted by some of his colleagues, but in 1985 they were published in an article in the journal Clinical Radiology. He analysed one side effect, bowel damage, in detail. For the traditional radium pack, he found no cases of bowel damage in one full year and only one in another, less than 1% of those treated. For Selectron, using the full dose, it was 27%. In an unusual postscript, the article acknowledged the work of the surgeons who'd repaired the radiation damage caused during the trial.
The Christie Hospital owes a debt of gratitude to all those surgeons who have rescued many of our patients from their complications.
At another Selectron conference in 1988 in The Hague, Dr. Robin Hunter gave the hospital's official figures from his study of major and minor problems in an early group of patients. 7 years on, those given the full dose showed an injury rate of 57%. So what had gone wrong? There were some answers in the article one Christie radiotherapist published in 1985. It said there had been 2 errors in the conduct of the trial. One was that the pilot study had been too small before launching the trial, just 12 patients. The other was that 2 untried techniques, Selectron and Hex 2, had been used at the same time, making it hard to disentangle the results. But was it the Selectron machine itself, or the way the Christie doctors were using it that caused the damage? Surprisingly, the article said that the dose rate had been undeservedly blamed for most of the injuries to patients. There was a different problem. Pushing the new metal tubes into patients could stretch their internal organs and expose their bowel to greater radiation. The article came down in favour of the traditional radium pack.
By contrast with the Selectron, the Manchester radium system can now be seen in perspective as an almost trouble-free and ideal radiotherapeutic technique.
For Nucleotron, the manufacturers of Selectron machines, this hardly formed a good advertisement for potential customers in other hospitals. A problem for their managing director in Britain, Carl Pavey.
From a manufacturer's point of view, I think it's very important for me to state that Nucleotron is supplying a tool with which the doctors can treat their patients. In terms of the dose rate question, which is a very important question, the initial Selectron and indeed subsequent Selectron afterloading machines which has followed have been able to treat at varying dose rates. We are therefore in an unfortunate position of being able to say to the doctor, based on all the evidence from other centres, including the Christie Hospital, which we're able to present at meetings and in our publications, you must make a decision on a purely clinical basis.
Have some other hospitals said to you, well, if there was so much damage done in the early days at the Christie, was this a problem of the machine or a problem with the way that they used it?
Experience has shown over the past 12 years that it is not a difficulty with the afterloading machine itself.
2 years ago, the surgeons who repair pelvic radiation damage at the Christie Hospital published a book on its causes and treatment. They said that the continuing injury and death rates were considerable among patients with serious radiation diseases. And they explained how they know.
All radiotherapy in the northwest of England is carried out in one centre which serves a population in excess of 5 million people. This central arrangement for the treatment of pelvic tumours has given us an unusual experience of dealing with several hundred patients suffering from pelvic radiation disease.
These surgeons still see new patients with radiation disease from cervical treatment, but they say that most of them were given radiotherapy some years ago. They think that the casualty rate now is about what it was before 1978. If they're right, then years of what one Christie doctor called turmoil may be at an end. But unknown numbers of women have been injured. To doctors, they're the morbidity rate. We've asked senior members of the Christie staff to estimate the total number of cervical cancer patients investigated for radiation diseases since Selectron and Hex 2 were introduced. They put the figure at 300 or more, about half of them so seriously damaged that they needed surgery. It was Dr. Robert Poynton who brought the Selectron machines to the Christie and went on to be Director of Radiotherapy for most of the trial period. Does he find the figure of more than 300 casualties from the new
I don't know if it's a reasonable figure. I will accept that it's probably an accurate figure, but over the recent years, of course, the incidence has fallen off very considerably to what I would accept as acceptable levels comparable to the previous treatment. No morbidity is entirely acceptable, but I'm sure that it is now well controlled and that the majority of the cases they're talking about occurred in the very early days of using the machine.
As far as the patients who've been damaged are concerned, if they said to you, you had an acceptable, well-proven system which you changed, you didn't tell me that you were trying out something new, but you did, and it did this harm to me, how could you respond?
Well, I think the only thing one could say was that everything that was done was considered to be done in the best interest of the patient and in the best interest of subsequent patients. It is always regrettable when there's morbidity occurs. The only solace one can get is just to point out is that their cancer had been cured. But as I say, it isn't something that one wishes anybody to suffer, but nevertheless, there will be always, with any treatment, a certain morbidity, and that I think it is now acceptable, or within acceptable limits.
In medical schools, doctors learn a Greek word they hope not to hear during their professional careers, iatrogenic. It means caused by a doctor. The profession is currently concerned about what it calls medico-legal consequences, doctors getting sued. Some of the women damaged by the Christie Hospital have asked a Manchester law firm to look into their cases. The firm specialises in claims of medical negligence under one of the partners, Anne Alexander. But showing that doctors have caused damage is a long way short of proving that they were negligent.
There's no system in being for no-fault compensation. In other words, for somebody to be compensated simply because they have been damaged, they have to prove negligence. They have to be able to show that a treatment has been given to them which has failed to meet a reasonable standard of care and that the treatment that they have received has caused damage. One has to look at what is a reasonable standard of care. And if the health authority responsible can show that a reputable body of doctors had come to a decision about that reasonable standard of care and that it was reasonable at the time, bearing in mind the practices at that particular time, then any person who was bringing a claim would fail. And in that instance, they would not be able to prove negligence.
It was this point of law which in March put an end to another patient's High Court case against her radiotherapist from a different hospital, the Royal Marsden in London. Lady Audrey Ironside was damaged by treatment for breast cancer in 1982, and her story bears a number of similarities to that of the Christie patients with cervical cancer. Lady Ironside was given radiotherapy as a precaution after surgery to remove a lump from her left breast. Like the Christie patients, she recalls a very positive account of radiotherapy from her hospital when she and her husband asked about long-term side effects.
I was simply told, don't go looking for trouble, that it was ordinary routine treatment, that there were only very temporary side effects of nausea and exhaustion, and that I was to attend 3 days one week and 2 days the other week. And I was told there were no permanent side effects whatsoever. I was never warned of the risks of this treatment and the fact that I could be left with a useless arm and in great pain for the rest of my life.
We've spoken to other breast cancer patients treated at the Royal Marsden at about the same time. They too remember no warning of long-term side effects. Some of them were given the hospital's booklet about the effects of radiation.
What happens after treatment is finished? From this booklet you will see that radiotherapy affects some normal tissues. However, these effects are temporary and the normal tissue will recover.
But Audrey Ironside suffered permanent radiation damage to the nerves controlling her left arm. The symptoms took 2 years to appear, and then they just grew steadily worse. As at the Christie Hospital, the problem stemmed from a change in an established procedure. For years, the Royal Marsden's breast treatments consisted of 30 small doses of radiation given over 6 weeks. But hundreds of patients, including Audrey Ironside, were given only 15 doses, each of them almost twice as big, because of a shortage of machine time. The technique was abandoned in 1984 because of the level of skin damage it caused. In March this year, Lady Ironside brought her case to the High Court. Her radiotherapist conceded that the treatment had caused the damage to her arm. But the doses had been agreed by a committee of doctors, and to win compensation, she would have to prove not only that they got them wrong, but that they'd been negligent. If she failed, the costs for both sides in the case could have ruined her. So after 6 days in court, she gave up.
I think it leaves the patients absolutely nowhere. It puts the doctors above the law, and I think that it's been a great eye-opener, my case, to a great number of people, that there is no justice for patients if things go wrong. There'll be no compensation. They don't even say sorry, and you're just left to get on with it while they sweep it quietly under the carpet.
But reading about her case, other women given the same treatment at the Royal Marsden and other hospitals, and damaged in similar ways, wrote to Audrey Ironside, saying they wanted to look for redress. One of them, Liz Talbot, is preparing a case over the damage to her left arm.
I mean, of course it's wonderful that people are alive from cancer 10 years later, but how long have you got to be grateful for? I think I'm suffering the least amount of pain. Some people are on morphine and really their lives are absolutely shattered. And most people feel that we need compensation. And I mean, if the various hospitals think that we're just going to lie down and take it, I think they're wrong. I mean, we have got a voice, and people feel quite sort of militant and angry. And I hope that someone somewhere will have to know that we exist, because we don't intend to keep quiet.
The failure of Lady Ironside's case for compensation demonstrates a problem for the Christie patients who've been damaged by radiotherapy. But their solicitor is taking a different course, based on the principle of informed consent before treatment. One of the patients is Emma, who's 30. 5 years ago she weighed 9.5 stone. Now she's just over 5.5.
I learnt on the ward that the radiation boost could be either a Selectron or a pack. I learnt this after I'd had the Selectron, but I wasn't given a choice. And I just learnt that the radiation pack was something that you had in bed for 3 days. I observed on the ward, because there was other women having the pack on the ward. And also during the surgical time, I found out that many of the women that were having surgery from radiation disease, most of them, through talking to them, because you're with them for 24 hours, most of them had had the Selectron. So I sussed out for myself that that may be the main cause of the radiation problem.
Did you ask the hospital why you'd not had the 3-day treatment rather than the faster treatment?
No, I didn't. No, I didn't at the time, because I really believed that they knew best.
Was it ever explained to you?
No, never explained. Even though I had asked them to be completely honest with me at the beginning, it was never explained why I had the Selectron instead of the pack.
We've interviewed 9 patients treated at the Christie Hospital for cervical cancer between 1980 and 1988. Their recollections are consistent. They weren't told beforehand that the hospital was trying out new techniques of treatment. 8 of the 9 say they weren't warned about long-term radiation disease, even though most were given radiotherapy after doctors knew of the greater damage they'd caused with the new treatments. The hospital's medical director, Dr. Robin Hunter, remembers it differently.
Patients prior to treatment were told that we had in this hospital 2 alternative forms of treatment, and an attempt was made to explain to them what would be involved from their point of view if they in fact had one or the other form of treatment.
We've spoken to patients, 9 patients, who cover 8 years of the trial. Not one of them has a memory of anything like what you've said being explained to them. They all say they had no idea that there were 2 treatments and that one of them was on trial.
Well, from the point of view of the individual patients, obviously I have to say that if they feel they have no memory of it, that I'm unable to check that at this situation. But I know that this hospital, and in particular the nurses involved on the afterloading side, were making major efforts actually to introduce the patients to the treatment beforehand. The patients, of course, prior to the procedures also had to sign a consent form since they were going to have an anaesthetic, and part of the consent form involved writing down the fact that they were going to have intracavity treatment.
But once you knew that there were some problems and they were rather greater numbers than you were used to, what did you tell new patients about possible side effects?
We told patients, I think what we always tell patients, that when you have a course of radical radiotherapy for curative treatment of your cancer, that there is unfortunately a risk that you will run that there will be some damage to tissues, and that tissue damage might, over a period of years, result in damage to bowel or bladder, sometimes perhaps even the vagina, and might require surgical correction. We also told them, I think, that we believed that it was in their interests that they should have the best treatment which the consultant felt was suitable for them at that particular point in time.
The question of how fully patients were informed about new treatments and the Christie's clinical trial will be central to any test cases their solicitor, Anne Alexander, decides to bring.
We'll be looking at whether or not they were aware that they were part of a clinical trial. We will be not only listening to what they have to say about it, but we'll also be looking at the guidelines that were in being at the time. And we'll also be looking at their medical records to see what evidence there is of any warnings that were given to them.
What should they have been told?
We believe that they should have been told that they were part of a trial. We believe that they should have also been told of any risks that the doctors were aware of, so that they could have made an informed choice as to whether to be part of the trial or not. And one will have to look at when their treatment was being administered to them to see actually what the state of knowledge was at the time about the risks that were known.
If doctors never tried new techniques on their patients, medicine would stand still. But patients have the right to go into treatment with their eyes open. For many cervical cancers, the most successful treatment is radiotherapy. However, there are important questions raised in the case of the Christie patients which apply across the whole practice of medicine. If patients can be cured, only to have serious injuries from their treatment, should they or their doctors decide how great a risk they run? And if, as the patients in this programme claim, that decision was taken out of their hands, then who is answerable for the permanent radiation damage they suffered?